Hello everybody, this is Tom Edrick and this is Ultrasound of the Month for November. Today we have a guest speaker, that's Dr. Dirk Varelman, well-known anesthesiologist and intensivist at the Brigham.
Hi. We have nothing to disclose. We have a patient who underwent hip replacement about 2 months ago, who had a prolonged and very complicated postoperative course, which was complicated by a ventilator-associated condition. He had postoperative atrial fibrillation with a rapid ventricular response, which was rate-controlled on actually digoxin and a beta receptor blocker. He had previously mild to moderate tricuspid regurgitation. He was suffering from renal insufficiency. After all those aforementioned issues were resolved, the patient went out to a rehabilitation center, and after about a week being there, he became anuric. He had an altered mental status. He became lethargic. It was noted that he had a distended abdomen, which was non-tender. For all those aforementioned issues, he was readmitted to the ICU. Immediately upon arrival, it was noticed that he had a low blood pressure. The patient had an increase in creatinine to 4.2, had a BUN of 232, which was rising over the past 5 days. The patient is, as mentioned, lethargic but arousable, and on physical exam we didn't notice any focal deficit. In the setting of an acute kidney injury, in the status of failure, a stat renal consult is requested. The renal consult team is coming by, seeing the patient, and they suggest that the patient should be challenged with a fluid bolus, either with crystalloids or colloids, to increase its preload and to see if the patient is making any urine with this fluid challenge. A fluid bolus with crystalloids or colloids to increase the preload is suggested to see if the patient is making any urine with this fluid challenge. They also suggest a renal ultrasound to check the urine electrolytes. As the patient looks fluid overloaded instead of intravascularly dry, we decide to perform a bedside transthoracic echocardiogram. On the peristernal long axis view, we noted that the LV is adequately filled and there is good contractility. In the short axis peristernal view, we noticed that the patient exhibits signs of septal flattening in systole as well in diastole. Systolic flattening of the septum is typically a sign of a right ventricular pressure overload, which can be a result of, for example, pulmonary artery hypertension. Diastolic septal flattening is typically a sign of volume overload of the right ventricle. We were unable to obtain a good apical window, but on the subcostal view, which was actually of adequate quality, we noticed that the patient now has severe tricuspid regurgitation with a mildly reduced right ventricular contractility. The RV seems to be dilated. When looking at the IVC, we noticed that there is no respiratory variation. The IVC diameter is larger than 2 centimeters. This again also indicates that the patient is intravascularly not dry. On the hepatic vein spectral Doppler, we noticed that the patient has a large S wave, meaning that in systole there's flow reversal in the hepatic vein, which is typically a sign of severe tricuspid regurgitation, which can be a consequence of severe right ventricular fluid overload. So the ultrasound we obtained narrows down our differential diagnosis. Hypovolemia is unlikely as the reason for a lower urine output because we have good filling of the IVC, the RV is pretty well filled, as well as the left ventricle, and we have a lack of respiratory variability in terms of IVC diameter. An abdominal compartment syndrome is unlikely because the IVC doesn't seem to be compressed, although the tricuspid valve shows massive regurgitation with concomitant systolic flow reversal in the hepatic vein. Again, an indicator of severe volume overload. In the further course, placed an A-line for beat-to-beat blood pressure monitoring. We inserted a pulmonary artery catheter to obtain pulmonary artery pressures as well as a cardiac output cardiac index. We added inotropes to achieve a normal cardiac index guided by our pulmonary artery catheter. Instead of adding more fluid, we actually decided to start continuous veno-venous hemofiltration to take some fluid off. With a negative fluid balance over the next few days, we were able to wean off the inotropic and the vasopressor support. On a follow-up echo done by our cardiology colleagues, we found that the TR improved to mild to moderate from our previously severe tricuspid regurgitation.
Thank you very much, Dirk, and that concludes our Ultrasound of the Month for November. See you next month. Bye-bye.